So I hope that worked. We're are we ready for me to roll, Carl?
Yes, Doc.
Okay, thanks. So I hope that worked. And again, as Joe recommended, we're giving a minute for folks that are on that don't have paid YouTube to get through their commercial requirements. And we're also providing some statistics when we start on how many deaths have occurred with COVID-19 since it started versus deaths from heart attack. And it really doesn't include the permanent disabilities from stroke. So as you can see, even in the height of the COVID-19 epidemic, we're still, more of us are dying from heart attack and stroke. So again, hope that message is getting across. And thank you so much, Joe, for suggesting that. Ralph, thank you so much for reminding me about Dr. Catherine Croft and her suggestion about 2-hour postprandial insulin. So what Ralph was telling us is that Dr. Croft has pretty good reason to suggest that 2-hour postprandial insulin is more important than even OGTT and Kraft insulin survey. Now, I will tell you, we'll discuss that a little bit further if we get a chance in the Q&A. I'd like to. My biggest question is, you know, with a insulin survey, it does include, one of the components is a 2-hour postprandial insulin, but it gives you a lot more information as well. So we'll have to have a little bit more discussion about why that one number is better than about 12 numbers. Either way, that's a critical number, and that's one of the most valuable numbers in the OGTT with insulin survey. If all of that sounds really weird, wait till the Q&A, we'll cover it. Today we're going to be covering, for the COVID-19 section, the primary topic, the feature topic will be inaccurate death certificates. You know, prior to COVID-19, what was it? Was it 1 in 3 or 2 in 3 death certificates had the wrong information? The reason I don't remember and frankly don't care is that's a number that the experts have added to it. Here's why I don't care about that number. I'll give you one of the most common examples and one of the biggest issues around it. But I'll do that later. So upcoming topics: privacy issues with contact tracing apps. We're starting to get out into the world, the work world, gearing that economy up, getting back out there. But how do you do contact tracing? How do we draw a circle around and protect others when an outbreak starts happening? Software issues, and again, the privacy issues that come along with that. Fewer people doing social distancing, even before the states open up. You know, Janice and I are seeing that here in our little town. The first time we went out and took a drive, it was amazing to me. It was like the whole town had shut down. It was like a ghost town, like a post-apocalyptic movie. But we went out again a little bit later, and it's starting to look a lot more like normal. There's an office building that's less than half a block from us. Parking lot's full every day. So that doesn't really look like COVID-19 shutdown. And well, we'll talk about that. That's an upcoming item. On Tuesday of next week, we're going to have an interesting discussion with Doug Thompson. He came on before. He's a dentist that developed the Wellness Dentistry Network. It's a dentist network where the dentists are actually looking at the impact of oral health on our body. As you may or may not know, most people don't know, gum disease is very much related to heart disease. Now, there's a simple, easy answer to that, and that is gum disease is extremely related to diabetes and prediabetes. Need I say more? So Doug has developed a network of dentists called the Wellness Dentistry Network. And these are dentists that are beginning to understand the importance of what they can be doing and the missed opportunity from a public health perspective. Well, you know, just as Doug gets that group up and rolling, COVID-19 happens. And I can tell you, as you may remember, I'm doing about half my time right now on working with large employers, getting employees back to work safely. I don't know. I've seen now a lot of employers have major challenges, like the meat packing plants. We talked about those a couple of times. I haven't seen or met an employer yet that's got the routine challenges that dentists have. Now, Doug is on a national group to help other dentists figure out how to get back to work safely for themselves, safely for their patients in the COVID-19 outbreak. So what Doug's going to be doing with me on Tuesday is just walking through some of the things that he's learned and some of the things that he's helping his dentists with. What does that mean for you? Well, at some point, you're going to need to go back to the dentist, right? It might help for you to know what your dentist should be doing. So more interesting upcoming topics. You know, whenever a pandemic occurs, and we have a flu pandemic usually each year, it's a seasonal thing. You could argue about whether or not it's really a, quote, pandemic. The bottom line, it is transmission of disease with an independent outbreak epidemic progression in multiple countries at the same time. That's one of the standard definitions for a pandemic. So when you look at it that way, yes, we do actually have a seasonal flu pandemic each year. Now, when you look at things like flu pandemic or any other pandemic, the virus tends to mutate. And as it mutates, it usually becomes a little less virulent and a little more contagious. Now, there is a significant evidence coming from Los Alamos, believe it or not. Yes, Los Alamos, the government high security rocket group, looking at evidence of potentially the New York virus starting out with the European version, not the Chinese version, but the European version, and then quickly being overtaken by a new mutant. Interesting story. So again, that's coming up. Can herd immunity be achieved without vaccines? The obvious answer is yes. The real question is, can and will our society take the pain and death rate that it's going to require? Coronavirus, next topic, coronavirus may have been in circulation long before it was identified. So also, assuming that's true, and I'm assuming that it is true, and it's not a surprise. I don't think that's going to surprise a lot of folks. Items we have covered, does sunlight and microwave kill the coronavirus? And again, it's not so much a question of whether that happens, but what to do with it. So we've got a topic on that. Carl is taking these primary topics, cutting them into short 8 to 12 minute versions. So if you'd like to see one of those on these topics, please email us, let us know. We'll be happy to get that out there for you. Other topics we've covered, COVID-19 condition emerging in children. It was an inflammatory condition similar to Kawasaki's disease. It's rare. It's rare. It's not some. We had somebody, as usual, accused of fear mongering. We're not fear mongering. It's rare, but it is something that folks need to be aware of. I think more than anything else for kids, it's the exception that proves the rule that kids are not at a huge risk. The race for the COVID-19 vaccine. There are 80 different vaccines, 80 to 90 that are being developed right now. There are 4 or 5 different mechanisms for it. If you're not aware of those facts and what those mechanisms are, and Richard Lunn, what mode RNA or Moderna is doing in terms of the new genetic vaccine carrier, take a look at that video. It's very, very interesting. We're covering an article that was published in Nature magazine. Mysterious blood clotting complications. So here's the issue with that topic. You see 30-something-year-olds that are otherwise healthy having major strokes, not just strokes, major strokes. You had a healthy young actor on Broadway lose a leg because of blood clotting that's happening with COVID-19. Very interesting topic. And then pulse ox. By the way, I was able to get my pulse ox working, sort of. I had a battery problem, so I was able to get the battery problem fixed. But as I go in and work on it now, I still can't get the reading. So $60 on Amazon, not much help yet. So those are some of the previous topics we've covered. Next, we'll go to just some brief reminders on some other issues. We've covered this a couple of times. Remdesivir, the only medication that's coming out with any kind of significant positive ongoing CRED, a 30% decrease in time in the hospital and a 30% decrease in mortality. Again, if we've got slots available if people need help in terms of just routine urgent care while you're locked in with COVID. Biggest issue, one of the biggest things that you can do for your health is find out if you're one of those, about 150 million people in the US that have prediabetes and therefore burning their arteries, therefore setting themselves up for heart attack and stroke, and don't know it. And you say, well, that's just too expensive. Doc, it costs $1,000 to $4,000 to see you, and you're too, $179 to find out if you've got that going on. How much did you pay for your car? For this kind of life-saving decades, adding decades to your lifespan, I think $179 you can probably start figuring out how to get that. And if you can't, you know what? Check in with Michelle. We also are open to doing a scholarship for folks in financial need. CIMT webinar. Bunch of you have had CIMTs at a David Meintz event, a Todd Eldridge event, or a Doug Thompson event. You got great information. You got a good warning about whether or not you're burning your arteries. You didn't have a doc, so you took it to your doc. Your doc didn't know anything about it, therefore assumed that this was not helpful. Therefore, you had a great life-saving warning regarding your health, but ignored it. Again, we've got a seminar now. Michelle has been doing some great work on getting these projects up and rolling, and that's available. Last item, working on the book. I'll keep you posted. Bottom line on the book is this: unless you're feeling lucky, don't depend on a stress test to tell you whether or not you're at risk for heart attack. So we can get deeper later if people have specific questions on that, but overall, I'll keep you posted. Now we'll get back to the primary program topic. The bad shape of diagnoses on death certificates right after Carl gives us the water ball. So, accurate death certificates. The inaccuracy is going to increase during the COVID-19. Obviously, you would assume that having an accurate death certificate is important to know where to send resources and develop resources and focus for fighting what's causing our death. Coronavirus, heart attack, stroke, you name it. However, the U.S. struggles to track COVID-19 fatalities due to spotty testing, delayed lab results, inconsistent reporting standards. And according to Bob Anderson, chief of the Mortality Statistics Branch at the National Center for Health Statistics, up to 1 in 3 death certificates nationwide were wrong before COVID-19. Remind me if I don't mention the example. I'll give you an example of why it's, in my opinion, it's really much higher than 1 in 3. And it's not something I would expect a statistician to understand. Death certificates regularly lack enough details to accurately pinpoint the cause of death. In a 2017 review of Missouri hospitals, around half of the death certificates listed an inaccurate cause of death. In a Vermont study, 51% had major errors. And in a 2010 survey, around half of physicians admitted they reported an inaccurate cause. The problem will get worse as the COVID-19 pandemic will undoubtedly inundate already overworked and sometimes untrained officials filling out the forms. Now, let's start talking about some of the reasons for the problems. The first one is expertise gap. And that's actually one of the areas of concern that I have. Who can legally sign a death certificate? For natural deaths, it's physicians in a hospital setting. That's where you usually get most of these. Coroners and medical examiners for homicides, accidents, suicides, natural deaths that occurred at home or in a non-healthcare setting. And in the medical examiners are generally physicians specializing in forensic pathology and can perform autopsies. Coroners, though, are not always doctors, let alone pathologists. In some states, the only requirement for a coroner is that they are a non-felon of legal age. And I will tell you, that used to be much more of a trend. Between 50 and 20 years ago, there was a much bigger trend of having coroners and medical examiners as more of a physician, at least. Given the work that I've done in supervising physicians, as I mentioned on one of the chats earlier, I was supervising one of the docs that happened to be the ME for one of the gangland killings, and is an interesting thing. It's not personal information because the individual's now dead, but it's stuff I'd have to discuss on an individual basis. Interesting stories come out of this, but back to the topic in terms of inaccuracies. In some states, other medical personnel like nurse practitioners or physicians can sign off as well. And even medical experts, even a pathologist, can get it wrong. Let me give you my example. One of the most common causes of death is heart attack, right? But let's go back one step further. Quite often that heart attack results in loss of appropriate aeration. The patient's lungs begin to fill up. The patient starts getting heart failure. May get a pneumonia. They go into the ICU. The cause of death is listed as a pneumonia. And then they will usually, and they're supposed to go backwards a little bit to help you understand a little bit better why the pneumonia happened. Sometimes they will say pneumonia as a result of heart failure, and then may skip it at that point. But really what happened was this: pneumonia as a result of heart failure as a result of a heart attack as a result of a blood clot in the artery, blood clot in the artery as a result of plaque as a result of inflammation, and inflammation as a result of prediabetes, which in most cases the doc said didn't even exist. So as you begin to walk backwards in terms of root cause, you begin to realize why a statistician may see it as at least 1 in 3 is erroneous. But someone who understands the root cause of the illness, it's much greater than 1 in 3 in the beginning. So from my perspective, a lot of these statistics that you see in terms of cause of death are just, they're worse than, well, they're misleading, because they hide the fact that it's unrecognized prediabetes is killing so many of us. Reason number 2 for errors: a severe shortage of workers. The U.S. Justice Department has said that as many as 700 plus forensic pathologists are needed. That's the shortage. The shortage of workers equals a punishing workload. National Association of Medical Examiners has temporarily suspended that caseload limit of 325 autopsies per year due to COVID-19. So their caseload limit was what? Almost an autopsy a day. And pardon the imagery, but we're talking about sawing people's skull off, going into the brain, sawing their chest open to go into their chest. A lot. It's not a simple, easy, quick activity to do an autopsy. They're doing, again, their caseload limit has been 325, almost 1 per day for the year. Clearly more than 1 per work day. Now with COVID-19, they've blown right through that, and they said that's not realistic. We've got a lot more people that are going to be doing a lot more than that. So they're overworked. COVID-19, third issue here. COVID-19 is impacting the system at a time when it's already in a crisis, with a shortage of people doing the work. Again, just a repeat of the workload limit. That's from Dr. Ray Fernandez, the chief medical examiner for Nueces County, Texas, for 19 years. To complicate the matter, many medical examiners and coroners refuse to attribute a death to COVID-19 without a positive test before the person died. So someone catches COVID-19, they're in their house, they don't recognize that they're getting hypoxic until it's too late. They die. The body is brought to the hospital. It's put in one of those temporary morgue trailers out in the parking lot, and they're not going to test that body for COVID-19. Now, some are doing it, but especially in the beginning, they were saving the test kits for people that were alive. So yet another reason for problems with the count. Some examiners do post-mortem testing, but test kits are in short supply. On April 1st, April Fool's Day, the National Center for Health Statistics updated its website to clarify that COVID-19 should be recorded as the probable cause if testing isn't possible and if the medical records or circumstances support that. Now, to me, that sounds reasonable. To the, what's the word I'm looking for? The folks that assume that there's I'm having a senior moment. What do you call it when there's a whole bunch of them for the Kennedy assassination. You assume it was and I'm sure somebody will be giving me that number. If you're one of those folks that's assuming that there's a big one of those things going on, then this is it. This is where they're saying, no, gosh, now that I've had a word finding moment in front of an audience, I'll never remember that word. Oh boy. Still, some physicians will simply list pneumonia as the cause of death, even though pneumonia likely came after the COVID-19. So again, I hope sharing some of these examples has given you a little bit more of an understanding why something like this happens. And the term was conspiracy. Bullet number 3. That's the fodder. That's the fuel for those of you who are conspiracy theorists. Now, we'll cover that in this slide. In other news, the U.S. hospitals are said to be getting paid more to label cause of death as coronavirus. The American Medical Association is now, quote, encouraging, end quote, doctors to overcount coronavirus deaths across the country, says Minnesota Senator Scott Jensen. Dr. Jensen, Senator Jensen is also a doctor. So, Carl, I think we had a clip of this video. Is that correct?
Yeah, Doc, but we have another clip, which is a 2-minute video. This one is 4 minutes.
Okay, show that one if you would, the 2-minute one.
Okay.
Well, we often share with you the number of coronavirus cases and deaths, but there are questions about how those numbers are being reported. Our David Littman verifies whether finances are influencing the figures.
We show you numbers like this every day. The number of cases of COVID-19, the number of deaths, and the number of people who've recovered. But as those numbers rise, there's more and more scrutiny on them, especially on the death toll. We got a message on our text line saying doctors are reporting all deaths right now as COVID-19 deaths, and that they've been told by the hospitals to do it this way to get more money. To verify, we turn to the CDC and Forensic Medical Management of Texas. John Wayne is the chief forensic pathologist at Forensic Medical. He explained that a death certificate is filed either by a county medical examiner or a justice of the peace. It has a Part 1 and a Part 2. Part 1 is for all the conditions that immediately preceded death. Part 2 is for all the other significant conditions that a person had that may have contributed. The CDC put out a letter of guidance saying, if COVID-19 played a role in the death, this condition should be specified on the death certificate and that it should go somewhere in Part 1. But Wayne said anything in Part 1 is easier to find when it comes to research. And since COVID-19 is a high priority for doctors, scientists, and politicians, that data should be as easy to access as possible. But he said nobody gets paid based on a cause of death, so there's no financial incentive to list COVID-19. Money might be involved, however, in a different way. Minnesota State Senator Scott Jensen, who's also a physician, said Medicare reimburses hospitals differently if their patients have COVID-19. USA Today confirmed they get a lot more money if a patient has COVID-19 or needs a ventilator than if they just have regular pneumonia. Pneumonia and COVID-19 often happen together, so Wayne explained that a hospital administrator could try to change a discharge summary to get paid more, but he cautioned he had not heard any reports of that actually happening.
So for those of you who didn't get the point, yes, this is the Q&A section, and yes, on a couple of other things. Conspiracy theory. You know, they say fools rush in where angels fear to tread. And yes, I have a word finding problem. It's unfortunate. One of the first things that you start getting when you start developing senility is a word finding problem. That worries me, of course. I'm 62, soon to be 63, and I've had word finding problems. But here's the kicker. I've had word finding problems since at least the 4th grade. That's just nothing new for me. And why I would choose to stand up in front of an audience and do that. You know what? I feel very strongly about what we're doing, about helping folks become aware of the things that might shorten their life. So thank you, and 147 Degrees West, thank you for several others. It was conspiracy theory, and it actually came to me before I was able to get to your suggestions and notes. Thank you so much. Dave Murphy, oh my. Ralph, so here's an item that Ralph Alexander brought up, and I mentioned it earlier. He brought it up on our Patreon account, and Ralph, I tried a couple of times to respond to you. The Patreon technology was having a glitch, so I ended up sending the response back through Chris. I hope you got it. Ralph's point was that Dr. Catherine Cross, she did a PhD study, a dissertation on insulin, and she concluded that a 24-hour a 2-hour postprandial, that means post-challenge or post-glucose, insulin test is superior to fasting insulin and Kraft's OGTT with insulin assay. No question, it's superior to a fasting glucose. But here's what I don't understand, Rolf, and I haven't understood that from day one. A Kraft insulin survey includes about 8 numbers: a glucose and an insulin fasting, half an hour, 1 hour, 2 hours, 3 hours, and 4 hours. So that's what, 8 to 10 to 12 numbers, one of which is a 2-hour postprandial glucose, and another of which is a 2-hour postprandial insulin level. How can just a 2-hour postprandial insulin level be more effective than a 2-hour postprandial insulin level plus the corresponding glucose plus about 10 other readings? The logic throws me. Again, the reason I bring this up, though, is not to have a debate with you, Rolf. I really appreciate you suggesting this item. One of the absolute most important numbers out of that full craft survey is exactly what you're talking about here. That 2-hour postprandial insulin. It's very, very important. And how many people are getting it? So here's my thing. Almost everybody's doc is taking a fasting glucose, and a few are adding a hemoglobin A1C, both of which are totally inadequate for finding out whether or not you're burning your arteries, finding out whether or not you're at risk for heart attack and stroke. There are multiple ways to get much better information. That's really just an information thing. I do blame our docs, our standard docs. I don't beat up on them. I've spent a lifetime supervising them. They're people just like other people. I also have a bigger concern with the standards committees of medicine. The AHA, American Heart Association, American College of Cardiology, one of the most looked to groups. My own group, the U.S. Preventive Services Task Force, all of them are recommending inadequate solutions for early prediabetes. They all are. Thank you again, Rolf. Great point, great question. Thanks for bringing it up. And thank you for your perseverance and help in waiting for me to get through that dang tech on Patreon. Dave Murphy, love to hear it someday. Give us a call. We'll be happy to share that. I think he was talking about the story on the medical examiner. Apparently, the COVID deaths don't update as often as COVID. You may mean the other COVID stats. I think, David, you had shared, I'm not going to go back and try to find it, but some of this got started, this back and forth got started by David when he made a comment. It's one of those old Jimmy Hoffa disappearance jokes. And he said, yeah, they uncovered Jimmy Hoffa and found out that he died from COVID-19. Prandial, postprandial. Prandial means post-meal, post-challenge. Thank you, Joe. Again, I noticed that was a tech term, and I hope we got that clarification out there. So what we're looking to do is stress the body with a challenge from glucose, and then with the Rolf's suggested number, 2 hours afterwards, get an insulin value to see where the insulin is at that point. I would say get an entire picture of insulin and glucose over that 4-hour period. You get a much more detailed understanding of exactly how much insulin resistance you've got, how much activity you still have left in your pancreas. I was speaking with a patient yesterday. He agreed. I'm still a little bit nervous about using his name, but hopefully we'll be doing a video where he shows he shows a couple of OGTT with insulin responses, similar to the Kraft insulin survey. And he's walking me through it on his numbers. That's great. It's unfortunate that your typical patient has to learn that level, the level that people are learning on this channel in terms of the intricacies of preventive medicine and prediabetes. But the alternative is not really that time effective, because if you depend on others, including your doctors, to advise you correctly through this, you're going to die decades earlier. So again, don't mean to bang on other docs. The statistics are out there. They're very clear. other docs come out. They have to the doc's defense. Here's what happens, and I know I went through it myself. I supervise and train other docs that are going through this. They come out with a major focus on getting people healthier through medical school and residency training. And then they run through their first 300 patients where they're saying, your body fat mass is too high, you need to lose some weight. And they get really negative responses from patients when they do that. So they give up and they move on. And they buy a big house, they develop financial requirements, and they just get more focused on writing scripts and doing what your typical patient wants them to do. So this is not just a doctor problem, it's a societal problem. Douglas Pohl, what are your sources for statistics? Please show on the document. So if you're talking about that original document, we were mostly using the Hopkins numbers, and then the heart attack and stroke numbers, you don't find those. It's interesting. I've looked many times to see a weekly summary of heart attack and stroke numbers. You don't really have those. And in fact, we covered that in the upcoming book about why that's just not there. So what we're doing on the comparable heart attack and stroke numbers is we're taking last year's or the most recently available annual numbers, and we're dividing them up week by week. So Douglas, I hope that helps you, and it's a great question. And it's exactly where I go anytime I start seeing a number being quoted. PJ St. Pierre, thank you, good sir, for all you do. Thank you for the acknowledgement, PJ. And if you'd like to help us, Carl's got it up there. You can help through a super chat. You can help through a donation through Patreon. Both of those have grown more through the COVID epidemic than any time before. So again, we really appreciate it. I'm not drawing an income from it. What I'm doing is I've actually used, back when I was working, before my last retirement, I was putting my own, some money from my day job into this activity. 2 years ago, it was $80,000. Last year, I retired again and focused 16 hours a day, believe it or not, a lot of time on this. We broke even. We actually started paying back some of those debts, but bottom line is I've been mostly using my day job money to pay for this channel to get people aware. We're saving lives. There's no question about it. But I'm also saying, look, now that I'm trying to retire officially, I'm slowing down on pouring money into the thing. I'm basically subsidizing it with seeing patients. So any $5 that you guys can add to the cause, it really means a lot, emotionally as much as anything else. Bob Weiss, North Georgia Mountains. Good morning, Bob. Thank you. And thank you, David Murphy. David, you've been a very reliable and repeat person for contributing. And for those of you who don't know, David has lost, was it 100 pounds? It was like a major, major positive activity for his own health. And David, one of the things we haven't mentioned is there is nothing as powerful as seeing that happen in someone else to help to motivate people to take charge of their own health. So one thing you probably haven't noticed, you may have heard a couple of stories, Dave, but you have no clue the number of people you've impacted with your own taking charge of your health with your weight loss. Thank you so much for the contribution as well. Steve Mitchum, same here in Vegas. Thank you, Steve. Casinos are closed, but most restaurants are open and full of people. Yep. Ralph, thank you. Thank you, Ralph, for bringing it up. It was a great topic. Are you familiar with Dave Murphy? Are you familiar with Dr. Judy Mikovits and her take on all this COVID-19 stuff? I may have seen it. I'm blanking on the name, though. Sorry. her book, Plague of Corruption. Oh, I did see that. I saw a video on that last night. It was just released recently. It's been in the works for 18 months. As you know, how the book process goes. Oh, painfully so. Don't get a co-author. It's a major challenge. But the only, it's sort of like that old saying, the only thing worse than having a co-author is not having a co-author. It's pain if you do, pain if you don't. But anyway, Dr. Judy Mikovitz's book, Plague of Corruption, is out. Very relevant and timely to her current situation. Karen Black, $5. Thank you so much, Karen. I mentioned a few minutes ago how we've basically supported the channel. We're getting more and more support from viewers and subscribers, and we're taking any money from that, as well as any money. I'm spending a lot of time seeing patients as well. And most of the work that I'm doing for these employers, consulting, return to work, is going back into the channel. Thank you so much, Karen, for that contribution. Does my husband have to stop taking his beta blocker before an OGTT and insulin response to glucose test? It's a great question, and I'm going to take a minute on that. I covered it briefly on the chat. Here's the thing. A couple of the beta blockers do have a significant impact on glucose management, negative impact, bad. So if you want your husband's true non-beta blocker response, then you should probably take him off of it. Now, if he's on it because he just had an event 6 months ago, you may want to check with your cardiologist, and I doubt your cardiologist will feel comfortable with him going off of it. On the other hand, if you want to see what it's like while he's taking the beta blockers, and in many ways, that's the practical question. It's not what it's like when he's not taking them, if he's taking them all the time. So if you want to know what it is when he's taking them, have him continue to take them. So as you can see, that helps explain why I was saying you may want to do both. It depends on what your question is. The other thing I would say, I mentioned home OGTT. I'll go back to the patient I mentioned a few minutes ago, who's done a lot of his own work, OGTT with insulin response. You can do a lot of this at home as well. If you have questions on how to do that, again, please give us a call. That's what we're here for. 147 degrees west, conspiracy theory. Thank you so much. It's so frustrating to have a word, and it's always a keyword. It's not a and or the, and anyway, thank you so much. Conspiracy theory, yeah. Here we go, OGTT, are home OGTT available? There's an official insulin response, full-blown craft insulin response. We can help you get that, or you can just look up Meridian Valley Labs. Meridian Valley Labs. And we've got a lot of our patients have done those. It's a blood spot test. You do finger sticks. It's kind of bloody because there's a lot of sticks and a lot of blood, and you put that on a blood spot little sheet. You send that in, and then they give you the information. Dave Murphy, of all the things I've lost, I miss my mind the most, as you can see, and as I demonstrated today, I know very well what you mean. Chuck K, hi doc, for the next OGTT insulin survey, I've asked for 4 specimens. On my last test, I wasn't sure where my insulin was going after 2 hours. By the way, Lori is great. Thank you very much. And Lori, I'm wondering, Lori says it looks like Lori's still on. I hope, Lori, that you're hearing that and seeing that. As you guys, those of you who were on yesterday may know that we didn't get adequate notice or training for Lori, and she ended up having to do the co-hosting for me. There's a lot of technical juggling in the background that goes on with this. And I thought we did great. So, but again, Lori was under a lot of stress. Lori's been doing a great job. thank you, Chuck, and thank you for Lori, for what you did yesterday. Now, Chuck, I would tell you, it's very important for a lot of people who at least are familiar with and using an OGTT to understand a couple of things. One is the insulin response. You want to know how much insulin it's taking your body to manage the glucose levels that you're at. Number two, as you're mentioning, that's why the Kraft insulin survey goes on 3 and 4 hours. We now have that negotiated with Quest. Those of you who are getting those with us at Quest, if you want to do a full-blown Kraft, sort of a Kraft, here's the difference between it. Even with, well, I'm starting to confuse things. A normal OGTT is just glucose. It's fasting glucose 1 hour and 2 hour, and it's 75 grams of glucose. A full-blown Kraft insulin survey is 100 grams of glucose, not 75 like you see in the OGTT. It also adds insulin at every one of those levels. So you get a basal or fasting insulin plus 1 at every hour after that. And as Chuck K is talking about, here's what took me down that bunny hole. Chuck K's comment about, I wasn't sure where my insulin was going after 2 hours. That is a really good question. One of the bigger things that we tend to see is what my patient was describing to me yesterday. He had a phase shift. His first phase of insulin was not working so well, and the insulin, he was having to generate all of that insulin anew, as opposed to having significant stored insulin like a 25-year-old would have. For those of you whom this got a little bit confusing for, part of it's with me jumping around, but part of it is there's some significant stuff here that you need to learn. Hopefully I'll be putting out a video in a few weeks with one of my own patients demonstrating what he learned in this area and how that's impacting his health. Actually got a reversal of his coronary calcium score. Let me repeat that. 2 of my most popular videos have been me reversing my own arterial age, my plaque, and someone that worked with me for a while, a fellow named John, who reversed his calcium score. We have another patient who very, very likely appears, he clearly got a decrease in his calcium score, and it clearly appears to be from improvement in health. And we're going to go over that in his video. Joseph Page, Dr. Brewer, do you see any data on how much the social distancing has lowered the regular flu season numbers? The problem with that is, what's the number that would have been had we not been social distancing? Are you going to say, well, that was the numbers for Kentucky versus New York? Or are you going to say, what would New York have been had there been better distancing? My point is, I think we all understand it's had a huge impact. I mean, that's what stopped or slowed the epidemic down in China. It slowed it down in other places. And I hazard a guess, I hate to say this, I know there's a whole bunch of public health literati, whatever, conspiracy theorists who are saying we're killing the economy and we don't care. But here's what I do think is going to happen. I'm not trying to make policy for the country. I did come out with one video saying early on I felt like we should close the schools. And yes, we did the next week. But I'm not voicing opinions anymore on whether or not I think we should be opening up. It's a bigger political item than I could influence. What I do think will happen is that we're going to open up. We've already opened up on a practical basis much more than you would imagine. We will show some numbers on that soon. And I think it remains to be seen if there's significant deaths associated with it and cranking back up of the epidemic. We'll slow back down in some places. Jim Hyde conspiracy. I knew I was going to get that a lot. Thanks so much for the help. Steve Mitchum, I wonder how the total number of U.S. deaths compared to that from the same period last year. the seasonal flu virus ended up being pretty steady from what it's been before. If you're talking about heart attack and stroke deaths, those have, quote, decreased, but, quote, with the assumption that those are now becoming COVID-19 deaths, because the same people that are at risk for heart attack and stroke are now at risk for COVID-19. Joseph Page, Dr. Brewer, have you seen any data on, oops, I think maybe we went backwards here. Can I gift webinar series to friends and relatives? Yes, you can, Chuck, and that's a great idea. Actually, I see that a lot with spouses, especially, you know, men are the, and don't hate on me, it's true. Men are the inferior gender in terms of heart attack and stroke. We have heart attack and stroke earlier than women. And I typically will see a wife providing this for a husband. Now, most recently, we had that happen, and the husband was fine, and the wife ended up having a lot of problems. So if you're one of those wives thinking about getting it for your husband, think about it for yourself too. Emma Zahn, have you looked into nootrophy for memory enhancing? I don't know what nootrophy is. I'll tell you what, I did spend about, gosh, 6, 9, maybe even 12 months working with one of the memory programs. It's a software. I can't remember the name of it right now, but I will tell you, it did help that short-term word finding a lot. I've gotten so busy. Again, you know what? I've agreed to, I'll take some of the hit in terms of word finding if it gives me another few hours, if it gives me another half hour a day to help people get back to work. So it is what it is. Thank you, Amazon, though. I will say this, there's no question, these, the memory exercises do help. There's no question about that. Ralph, you need to let me know if it's Rolf or Ralph. Anyhow, thanks for offering this great service. Should be on the list of top health sites for everyone who's over 40 or over 30 and would listen. Thank you for that comment, Rolf. And I will tell you, there's a lot that you can do about it. If you'll share this, for example, on Twitter, Facebook, any of the social media, the more you do, the more you share, the more you subscribe, the more you do those things, the more the YouTube algorithm reads that and says, you know what, real humans thinking or looking at this and they're suggesting it. It's got to be important. Steve Mitchum, I just went back to work. I'll make a donation after I get my first check. Thank you very much, Steve. I do appreciate that. And for those of you who are having trouble with income because of COVID-19, thank you so much. But do the same thing Steve's doing. Wait till you start getting checks again. I mean, we can certainly use the money. It's a big deal for us emotionally when viewers and subscribers pitch in, but don't put yourself don't increase your own financial risk right now. Wait till you're back and rolling. Richard Lund, the Lutheran hot dish origin of the coronavirus, explains recombination. You know, Richard is a very, very sharp guy in this space. I've never heard of hot dish, though. I don't know Lutheran hot dish. Richard's also got his own YouTube channel, and he's actually helped us out with our lighting and got me to get that camera. Finally helped push me over the edge to get a Canon 80D. Thank you so much, Richard, for your help. Rolf, is a craft OGTT useful for those of us who avoid net carbs like the plague? Here's what it does. My answer would clearly be yes, because you don't know what shape your pancreas is in, and you don't know what shape your insulin receptors are in. The original offending problem is your insulin receptors, and there may be hormonal reasons, aging reasons, clearly things like body fat mass reasons. Any of these things can push on that insulin receptor. But the natural progression is for it to continue to get worse as we age. And so I do recommend that you check that at least once a year. And if you lose 30 pounds, check it after losing 30 pounds, because that has, that kind of weight loss, that kind of fat loss has a massive impact on carbohydrate management. Increasing muscle mass is a critical thing for people, especially if you get into the mid 60s. There's a great case to be made that loss of muscle mass is the most important thing in terms of avoiding heart attack and stroke in the future. Believe it or not, and most people haven't heard that. It has to do with the several things we can talk about later. Dave Murphy, any chance of getting links to the videos of your lowering CINT and the lowering of CAC? Lori, would you mind? I know that we have some. Lori, if you'll talk with Chris can help get some of these links up and make those available. Dave, if you or others who have an interest, if you'll just let us know what video topics you want to get information on, we can get that information for you. It's hard to find it. We've got over 700 videos, and the algorithm gets old and cranky, just like a mule. 170 Barbara, nootrophy or nootropic. There's several out there. Again, thanks, but I'm not that familiar with them. Steve Mitchum, don't worry about the word finding difficulties. We all get them, but we're not uncommon. Rolf, even if your system has become unaccustomed to dealing with carbs, well, try it, Rolf. Try it and see. You'll find that your system, it's like riding a bicycle. Your system may be, quote, unaccustomed, but it will respond, and it will tell you, it will give you a lot of information. One of the things that I find that it helps do for myself and a lot of others is it helps gauge what's happening. And it also helps motivate us to feel like, yep, I'm never seeing my blood sugar go over 120. Maybe I'm cured. You're not cured. We hardly ever cure this unless we lose 30 pounds or more of fat mass. I recently, about a year, not quite a year ago, maybe close to a year ago, I started pioglitazone. And it was very interesting. I had been hitting peaks routinely of about 160 to 180 after adding just pioglitazone. And I wasn't taking it every day. Take it 3 or 4 times and then stop 3 or 4 times. Now I'm taking about 2 or 3 times during the week. Low dose, minimum dose, 15. First time in years that I got a peak, it was like 130. Significant improvement. And again, the only real difference at that point was the pioglitazone. So Ralph, you get a lot of really good information from looking at it. Steve mentioned that was supposed to read, we're not on camera. You're right, I know. I figured that's where you were going with that. In other words, Doc, either you're foolish or you're brave or whatever, or motivated, but you're getting on camera with the same word finding problems that many of us have. Amazon, Hydrogene is a drug made by Sandoz that does change how the brain works physically. It's not a game. Thank you. I appreciate you clarifying. I think it improves how the synapses work. There are a lot of drugs that do help for Alzheimer's. I will say this, Amazon, there's a lot of drugs that say they help. We were doing a lot more Alzheimer's work. We're still doing some. Janice, for example, is one of the few people that you can find that actually knows how it is certified to do a MOCA, Montreal Cognitive Assessment, a critical part of a cognition evaluation. For those of you who've read The End of Alzheimer's by Dale Bredesen, I went to some 3-day training program with him, and every other phrase out of his mouth, he was talking about the MOCA. Again, Janice is one of the few people that the only person I know and know of that's trained in MOCA, and we've done a lot of work in it. One thing that we did find was that there were tons of medications that said we work great for dementia, and they didn't. So I hate to end things on a negative note, but thank you so much for your interest, and we'll be seeing you tomorrow.